Okay, so once again I get the tough task of following Mike. So can we have my next my presentation, please? Okay. So Odie asked me to speak about how the Irish Haemophilia Society interacts with the government and health authorities in Ireland. So first of all, we have about 900 people with haemophilia in Ireland, and we have about 270 with severe haemophilia. Over 1,800 with von Willebrand's, 806 with rare bleeding disorders, and about 350 with inherited bleeding disorders. You can actually see we have a higher proportion of people with haemophilia B compared to A than most countries. Now, the scientists will tell you that's because of founder effects and small gene pool. I think it's because people with haemophilia B are better looking and they have more children. But I have haemophilia B, so I'm biased. So our treatment history from 1995 to 1997, we started using recombinant factor for everybody with haemophilia. In 2017, we switched all factor 9 patients to extended half-life factor because we make a national decision. And in 2018, we switched all factor 8 patients to extended half-life factor. And then 2019, we switched all inhibitor patients to Hemlibra, but then it also became an option for every patient with factor 8 deficiency now has the option of Hemlibra or extended half-life factor. 96% of the children are on prophylaxis, and 95% of the adults are on prophylaxis. And in fact, especially with factor 9, we had a couple of holdouts who didn't want to take prophylaxis, but the fact that the extended half-life meant that they could infuse once a week, once every 10 days, or once every 2 weeks. So now everybody with factor 9 deficiency is on prophylaxis. I think the background to our development and the background to our relationship with government has come from successful and persistent advocacy and from realising that if you want sustainable, better haemophilia care, you have to engage positively and constantly with the government and the health ministry. So in 1989, we had a campaign for compensation for our members affected by HIV. And quite bizarrely, in fact, our then Prime Minister, when they lost a vote in the Parliament, called a general election on that issue. And he subsequently lost seats at the election. So there was a strong political memory of haemophilia. In 1991, we did a further compensation campaign for HIV. In 1994-97, actually, we worked on compensation for hepatitis C, but with the ministry. We didn't have to campaign for that. And then from 1997 to 2001, we had discussion on terms of reference for a tribunal of inquiry into contaminated blood, into HIV and hepatitis C infection. And then the inquiry itself in 2001 had very, very massive media coverage. All of the daily newspapers covered it for the entire year. And in 2002, the inquiry reported, but crucially, there was a large section with recommendations for the future. And we put a lot of work, not just into looking at what happened in the past, but thinking about how we make a better future. And this is from the 1991 campaign. The 1989 campaign, our first booklet on AIDS and haemophilia. And this was part of the compensation campaign in 1991. That was actually the night that the compensation was announced. That's a much younger version of me with the then health minister on television. So our contaminated blood inquiry in 2002, we used that very effectively to set future direction. I think it was very cathartic for our members. They got a government apology, they got compensation, but they also felt that their story was heard, understood by the public, they'd been listened to, and they really have moved on in a very positive manner. But I think the key thing was that we thought very clearly about the future, and given the devastation of HIV and hepatitis C and the vast number of deaths that this caused in our community, we thought, how do we make sure that in future, this doesn't happen again, that we have the best possible haemophilia care? And the answer is to be in the room, to set up structures that allow for that. So there was a statutory National Haemophilia Council established, which includes the Health Ministry, the doctors from the key haemophilia centres and the Irish Haemophilia Society. And we also established a tender board, a haemophilia product selection and monitoring advisory board. And this body advises and basically selects the products for all the haemophilia and von Willebrand and bleeding disorders patients in the country. So we have one committee that selects the treatments for the entire country. And that also includes the Health Ministry, the key doctors, and the Irish Haemophilia Society. We have a national budget for replacement therapy. So not each hospital, not each region, we have a national budget. Our products are selected by the committee. We've done that very cost effectively, but also some of the savings that we've made from tender to tender have been reinvested in comprehensive care infrastructure. We have a close collaboration between the society and the individual centres, and between the centres collectively and the society. So that the council, the Haemophilia Council, has had the impact. Initially it started off and it was a little strange, but you now have 4 hospitals represented on that council, and you can stop them thinking about just their own hospital. They think nationally. Oh, I'd like an extra nurse, but you know what, the physiotherapist for this centre has to be a higher priority. The ministry love this, frankly, because the ministry get us to internally agree what the priorities are. So every hospital will always tell you, we need more doctors, we need more nurses, we need more physios. And the ministry can say to us, well, hang on now, for this year, collectively, for haemophilia for the whole country, you tell us what the number 1, number 2, and number 3 priorities are. So it actually helps the ministry as well. And the society also received the majority of our funding from the health service. So we are primarily funded through a government grant. But this also means the fact that we have the council and the product selection board mean that we have regular scheduled meetings with the key ministry officials. So we meet the officials at least 6 times per year, and the meetings take place at our office in the Irish Haemophilia Society. Obviously, the last 2 years they've been virtual, but our office has been the location for these meetings. We also offer assistance and training to new officials in the health ministry, so we will train them on blood products and haemophilia. We give them some background. We've developed contacts and a collaborative way of working. And I think the officials can become advocates for haemophilia within the system. We believe that we have a blood, tissue and cells division in our health ministry, and the more knowledgeable those officials are about haemophilia and the work we do, the more it benefits us, because they then engage with the condition and with the organisation. But we also need to understand their viewpoint and learn from them how the system works and how decision-making in the ministry works. We obviously have the contact details of the Minister's special advisors, and we use them as a preliminary channel to the Minister. So we have special advisors. Sometimes I think in Ireland their job is to keep the Minister safe from his own civil servants, but they're very good conduits for communication. If we have an issue that we want to discuss with the Minister politically, we will prepare a detailed memo which usually goes to the advisor in the first instance. But we also collect and use the outcomes of our work, including, and this is something that organisations don't normally do, including looking at the outcomes of previous funding that we've been granted. We try to be forceful but respectful and brief. The Minister and the officials' time is limited, so we don't engage in very long discussions. We summarise and brief them in that way. But we also have a clear ask and cohesion between the society and the doctors. So the Ministry are not getting mixed signals. They're not hearing from us as the patient organisation, this is the priority, and from the doctors, no, this is the priority. We have a clear consensus on the way forward. And also, we provide, and I provide information in other areas. I sit on the board of the Blood Transfusion Service. At the Minister's request, I chair a scoliosis co-design committee, and we also help the organisation with other NGOs, so at the Ministry's request. So we've got I think a synergistic relationship with the Ministry in many ways. But as I said, we measure the outcomes, and that's really important. And that's something many organisations don't do. So if you go to the Ministry or the Government and you look for funding for something, then how was that funding used? What were the outcomes of that? So this is the impact of our switch to extended half-life factors in Ireland. So we were able to go back the following year and say, look, this is the impact. We've seen higher trough levels, we've seen less bleeds. I presented this at the ISTH conference. We did quality of life surveys. We looked at a significant impact that this treatment had. If you look at our tender outcomes, so we've been doing these haemophilia tenders since 2002. At the end of 2019, we audited all of our work from 2002 to 2018. And we looked at the previous system we had, which is where the transfusion service purchased, and we had several purchasing. And then we looked at the EU average prices, and we looked at where our prices, how they changed. So the difference was compared to the previous system, we would have had to spend 175 million euros more to get the outcomes we had with the previous system. That was the amount that was saved from the health budget. And if you discount that for the real value, given the different years, that comes up at about 275 million, and we're now at well over 300 million. So basically, we have, since 2002, we have tripled our use of haemophilia treatment. We have moved to better and safer and more effective treatments, but the budget has been essentially unchanged since 2002. And as I said, we've also included 22 million in savings from handling fees and tax on handling fees. So it's not just the cost of the factor. You're looking at things like, at one point, our transfusion service was the contract holder. They were charging a handling fee. Then there was a VAT charge on the handling fee. So all of those were also removed. And as I said, some of the savings were reinvested. And interesting comparison with Belgium, because before we changed our system, we had a very similar system to Belgium. And I love showing this slide to Cedric Hermans from Brussels. But if you look at this in terms of factor use, Ireland's in the orange and Belgium's in the yellow. Factor use was about the same in 2002, higher in Ireland. So we now have higher factor use than Belgium. And in 2002, we were spending more than Belgium, but now we're spending less than half of what Belgium spends, despite the fact that we're using not only more treatment than Belgium, but all of our patients, all of them, are on extended half-life or Hemlibra. So we're using more treatment, better treatment, at less than half the cost that Belgium is doing. And this is the kind of information and feedback, frankly, you need to give to a health ministry if you're getting funding, because we can all go in and ask for funding, and everybody goes in. Minister, I'm sure you know this, everybody goes into your office and says, if you give us this funding, it will save money in the long term. You need to be able to show the outcomes. I think we also work collaboratively with them. This was when hepatitis C, when the new hepatitis C treatments came out. This is our current Deputy Prime Minister. He was Prime Minister at the time. We got him to open a conference that we organised on hepatitis C. He then came to our office for a meeting, but we persuaded the Minister and the Government to prioritise people with haemophilia for access to the new hepatitis C treatments. And the reason we were able to do that was that we were able to show again with outcomes that the previous generation of treatment, which had a success rate nationally of 51%, had an 80% success rate in haemophilia because everybody stuck to the protocol and we give them a lot of help and support. So that actually prioritised access for our members to the new treatments. And then, having done that, I think we thank the Ministry publicly for the outcome, because we were able to effectively eradicate hepatitis C in the haemophilia community. And again, so we made our case clearly, we provided the data and the evidence, but then we communicated the results publicly, and then we publicly thanked the Ministry for their help with this. And most NGOs don't do that. So I think there's a lesson there. It's not just, this is what we would like, this is the funding we need, but then you've got to look at, this is the outcome, and then you communicate that outcome as well. This was the Minister attending our annual conference in 2018, and at the time, we were using extended half-life factor, but I did flag to him that there was a new treatment coming down the line that we specifically wanted to use in the first instance for people with inhibitors. That was emicizumab. I introduced him to some people with inhibitors at the meeting, and then we switched to emicizumab pretty quickly afterwards. And the government and the ministry also co-funded a research project with 2 million euros called the Irish Personalised Approach to the Treatment of Haemophilia, and that's been a very successful programme over the last 4 years. This is World Haemophilia Day this year, so again, the message here was more just in terms of celebrating because it's 20 years since the publication of our contaminated blood inquiry report, celebrating the achievements, celebrating the improvement in haemophilia care, but also reminding a new minister that haemophilia is well organised, it's well funded, we are involved in the decision process, and please don't forget that. And in fact, the young boy and the older gentleman, they both have high titer inhibitors. It was his 66th birthday, and the 11-year-old presented him with a birthday cake, but their quality of life with inhibitors is going to be vastly different from each other. Now, the 66-year-old who has high titer inhibitors has had inhibitors since he was a child. He was getting 15 to 20 bleeds per year. When he switched to emicizumab or Hemlibra, he hasn't had a single bleed in the last 3 years. And the 11-year-old doesn't see any difference between having haemophilia with inhibitors and his younger brother who has haemophilia without inhibitors. So it's really positive. By the way, the 11-year-old then took off with the cake, and we didn't get any of the cake afterwards. This is from the Minister's press release actually for World Haemophilia Day, and he commends the work of the Society, the Haemophilia Council and the Product Selection Board and the treatment centres. But crucially, we work together with the Ministry and the centres on those bodies. We develop key working relationships with key media, and we use patrons. So the last 3 Irish presidents have been our patrons, and that's really important, because it's good for the profile of the organisation. And finally, I think haemophilia organisations need to be integrated into the decision-making nationally. You don't want integration in gene therapy, but you do want to be integrated into decision-making on haemophilia care. This is a nice example from Brazil where, they show that the increase in factor use over the years effectively led from this kind of situation for boys to this. And I think as we're coming out of COVID, and as governments are looking at health budgets, and as all of our countries have spent vast amounts of money in the last couple of years. I mean, in the UK, their limit for incremental cost per QALY was £30,000. My understanding is the cost per death avoided during COVID was £500,000. And that was good spending, and the government spent a huge amount. But COVID, impacted society, it impacted the economy. It wasn't just treating a rare disease like haemophilia. So I think governments are going to be looking at the need for more acute hospital beds, more doctors, more nurses. So we have to work with them. We have to move our advocacy from transactional to transformational. We have to really work closely together on co-designing the service. And I firmly believe that if you want to work successfully with governments and with health ministries, you don't go to them with a problem, you go with a problem and a solution. But you go with a solution that also fits in with the direction of the healthcare system. Thank you very much.